Hello, thank you for watching my review on the medications used in dementia. I want to preface this by saying that I am not an expert on this topic. The information in this presentation is for educational purposes only and is not meant to be medical advice, and to always consult your healthcare provider on what therapies are best for you and your loved ones. Let's start by defining dementia. This is a definition of dementia that I synthesized and tried to make as comprehensive as possible. Dementia is a disorder that involves impairments in memory, abstract thinking, making decisions, and performing daily activities. It is also characterized by progressive loss of brain function and often includes personality changes. It is not a normal part of aging. The term dementia is nonspecific, as it may refer to a number of distinct conditions. There are many types of dementia. However, the type that makes up the majority of cases is Alzheimer's dementia. We can see here that it accounts for about 60 to 70% of all cases of dementia. Stroke-induced neurodegeneration is another type that causes about up to 20%. Lewy body dementia accounts for around 15% of all cases, and there are many other causes, including ones listed here. The leading question in dementia research for a while has been the debate between the tau hypothesis and the amyloid beta hypothesis. So, this can be crudely simplified to: does amyloid beta lead to tau protein deposition, or does tau protein lead to amyloid beta deposition? So, which one is the true first cause of dementia? We can look at some more details here. Amyloid beta is a peptide that is the main component of the amyloid plaques found in the brains of people with Alzheimer's disease. The plaques are made of a flexible, soluble, and usually misfolded oligomer of mostly amyloid beta. They cause chain reactions similar to prion infections and are toxic to neurons, causing the breakdown of neurons. The normal function of amyloid beta is currently unknown, at least in humans. Tau proteins. They detach from microtubules and stick to other tau proteins, forming tangles that deposit inside neurons. The tau protein normally helps to stabilize the internal skeleton of neurons. While both tau proteins and amyloid beta oligomers are associated with dementia, it's really not clear which one is the first cause of dementia, as we discussed earlier. Let's look a little bit closer at the amyloid beta hypothesis. Amyloid beta was isolated from Alzheimer's dementia and Down syndrome patients originally, and they were thought to have shared a cause in the beginning. Additionally, amyloid beta is encoded on chromosome 21, further relating it to Down syndrome. However, modernly it is not known if the disease states are even related, or if amyloid beta is really even their first cause. APP is the amyloid precursor protein, which is a precursor to amyloid beta. PSEN, presenilin 2, postulated to regulate APP processing through its action on the gamma secretase. The gamma secretase is an enzyme that cleaves APP. Notch1 is also part of the amyloid beta hypothesis. It is a substrate of gamma secretase involved in tumorigenesis and determining the fates of neural and non-neural cells during development and adulthood. Interestingly, evidence has shown that disruption of Notch signaling and increases in Notch signaling may be associated with neurodegeneration in Alzheimer's dementia. Mutations in the APP gene and the PSEN gene have been linked to early onset Alzheimer's dementia. The epsilon 4 allele of the ApoE gene, or apolipoprotein E, has been associated with an increased likelihood of developing Alzheimer's dementia and a lower onset age of Alzheimer's dementia. ApoE is thought to regulate amyloid beta aggregation and clearance. However, its connection to Alzheimer's dementia in general is still poorly understood, and it may contribute to Alzheimer's dementia in ways not involving amyloid beta. Normally, apolipoprotein E, or ApoE, helps carry cholesterol and other types of fat in the bloodstream. DePaul et al. In 2009 found that amyloid beta oligomers injected into the hippocampi of mice induces Alzheimer's dementia pathology. Also, these oligomers interact with neurons and glial cells to induce inflammation, oxidative stress, and tau phosphorylation. All of these are related to Alzheimer's dementia. However, in times when APP is upregulated, like in TBI, or traumatic brain injury, this actually causes a neuroprotective effect. In addition, the evidence for amyloid beta targeting medications is poor, meaning that amyloid beta deposition may really not be the fundamental cause of neurodegeneration in Alzheimer's dementia or dementia in general. This slide shows a chart of alleles related to the gene that transcribes amyloid beta. There are many different forms of this gene in many different, even distantly related animals, in all around vertebrata or vertebrata, or essentially chordata, which makes up the majority of all vertebrates, including, for example, things like starfish, nematodes, lancelets, sawflies, wasps, ants, and bees, All of these have different forms of amyloid beta. However, its modern usage, including its usage in humans, is currently unknown, and it must have served many different purposes throughout history in many different life forms. Other genes related to Alzheimer's dementia, for example ApoE, are also ancient. Now, to contrast, let's take a closer look at the tau hypothesis. First, let's define neurofibrillary tangles. They are abnormal accumulations of tau protein that collect inside the neurons. Tau proteins come from the degradation of microtubules in the brain, which they help to construct. They become phosphorylated, and this gives them a reduced ability to promote microtubule assembly because they're not able to interact anymore chemically. Neurofibrillary tangles are also associated with neurodegeneration because they are neurotoxic. GSK3-beta, or glycogen synthase kinase 3 beta, is a protein kinase that facilitates the phosphorylation of the tau proteins, leading to them no longer being able to function. DePaula et al. In 2009 found that neurofibrillary tangles can also be found in patients with very mild dementia and no amyloid beta pathology, supporting the idea that this may be the true hypothesis. Brock et al. In 1991 found that tau pathology correlates with Alzheimer's dementia progression and severity more closely than amyloid beta plaque load does. Surprisingly, potential drug therapies focused on the tau hypothesis have also failed, meaning that it still may be more complicated than just this hypothesis. Tidaglosib, a GSK3-beta antagonist, failed to show clinical benefit in the phase 2 trial. TRX0014 and LMTM, or methylene blue dye derivatives, they inhibit tau aggregation and did appear to slow cognitive decline in phase 3 trials, but the results of their trials are quite controversial due to their methodology being disputed. And this is cited in Medina 2018. So what exactly is the answer to this debate? Unfortunately, there really is no mechanism for dementia solved still to this day. Numerous proposed mechanisms do exist. Many of these proposals suggest that the mechanism is actually multifaceted, and many include both tau proteins and amyloid beta as part of the entire function. In particular, many researchers currently suggest mechanisms that include amyloid beta promoting the formation of tau tangles, which then go on to damage neurons. However, we're still not clear if this is actually what's going on. I thought it'd be good to introduce this information from a 2020 review that has found additional modifiable factors that contribute to dementia. This is a review that comes from the Lancet Journal, a widely renowned medical journal. We have information from the review that says that 40% of the risk of developing dementia later in life can come from potentially modifiable factors that occur throughout the life. I have a further breakdown in the image here. However, the basic rundown is early life is about 7%, midlife is about 15%, and later life is a bit more important at 18%. Still, about 60% of the risk of developing dementia is currently unknown. Now let's shift to talking about medications for dementia, starting with Donepezil and MEMANTINE. Donepezil is one of the oldest FDA-approved medications for dementia, specifically Alzheimer's disease. It was approved in 1996. The study that led to the FDA's approval of Donepezil is listed here. The efficacy and safety of Donepezil in patients with Alzheimer's disease, results of a U.S. multi-center randomized double-blind placebo-controlled trial. The next bullet is an additional trial that occurred after the approval of Donepezil, looking at the function in Alzheimer's disease. There was an article published doubting the effectiveness of Donepezil later in 1999, and here in 2020 we're going to look at a more modern look at Donepezil. Let's take a closer look at the study that led to the approval of Donepezil. This is the first study we're looking at from the Donepezil study group. We have an N of 161. It is a randomized double-blind placebo-controlled multi-center trial, so it occurred in multiple centers. The doses were low by modern standards. Patients took 1 milligram, 3, 5, or placebo once daily in the evening. The trial length was for 12 weeks. Patients were assessed with the Alzheimer's Disease Assessment Scale, Cognitive Subscale, or ADAS-COG. This is the ADAS-COG 11, or the Alzheimer's Disease Assessment Scale, Cognitive Subscale, which was used in the study to assess the patient's cognitive symptoms of dementia. The categories are all listed here along with the scoring. It includes 11 items that are used to assess the severity of the cognitive symptoms of dementia specifically. The max score is 70 points. The higher the score, the greater the impairment, which is worse. So what is good about the ADAS COG-11, and are there any cons to this? So this test is quite accurate in determining the difference between normal individuals and individuals with impaired cognition. Another pro is that it has a wide range of possible values, making it quite specific, and it's able to determine the difference between readings. A couple cons include that this may be too easy to consistently detect mild cognitive impairment, and it is not a simple test, meaning that it is quite time-consuming. So therefore, this test may not be well suited for severe disease. Let's take a closer look at the results. So right here, we see a p-value here showing that the ADAS COG tests are showing that Donepezil 5 milligrams per day seems to be clinically effective. I do have on the green box, multiple measurements of Alzheimer's symptoms were used in this study. 3 of them found no statistically significant difference between the groups. So it is the ADAS COG test where we see the best data. This is a closer look at the ADAS COG scores of the different groups. We can see that the most favorable results came from the Donepezil 5 milligrams per day group, and it resulted in a lower reduction in mean ADAS COG scores compared to other strengths and placebo. Moving on to the 1998 trial, we see that we had an N of 468, which is a lot more than previously. This was a 12-week double-blind placebo-controlled parallel group trial with a 3-week single-blind washout. Patients were separated into 3 groups: Donepezil 5 milligrams, 10 milligrams, or placebo, all of them 1 qD/HS. The conclusion they found was that Donepezil 5 and 10 milligrams, administered once daily, is a well-tolerated and efficacious agent for treating the symptoms of mild to moderately severe Alzheimer's disease. Later in 1999, Steele and Glazier published "Is Donepezil Effective for Treating Alzheimer's Disease?", which casted a little bit of doubt on the effectiveness of Donepezil, looking back at the older evidence. It pointed out that the number to treat for Donepezil 10 milligrams was 5, and for 5 milligrams it was 7. It also stated that there's no evidence to date that indicates that Donepezil improves the quality of life of patients with Alzheimer's disease, nor is there any good evidence of the long-term efficacy and safety of Donepezil. It did ultimately recommend that physicians still consider giving Donepezil to patients in 9 to 12-week trials of Donepezil, if appropriate, and it also indicated that more research into Donepezil for Alzheimer's disease would be welcomed, they said. I also wanted to include a little bit of modern information about Donepezil, because it has more indications than just Alzheimer's disease. It has been shown to show some benefit in cognitive and behavioral symptoms in Lewy body dementia, also improvement in memory dysfunction in patients with traumatic brain injury. We do see improvements in cognition in patients with vascular dementia with Donepezil. However, the global functioning has not been shown to be significantly better. There also is some evidence that has been found to suggest that Donepezil can improve cognition, executive function, and global status in patients with Parkinson's disease dementia. Now let's take a look at MEMANTINE or Namenda. MEMANTINE was approved by the FDA to be used to slow the progression of moderate to severe Alzheimer's disease on 10/16/2003. We have a list of studies that accumulated the evidence for Namenda's approval here. The first study we'll look at is the MEMD-02. The N was 322, started with 401, a randomized double-blind placebo-controlled multi-center parallel group study. Placebo with Donepezil or MEMANTINE with Donepezil were the 2 groups. The regimen was 5 milligrams POQD for a week, then 10 for a week, then 15 for a week, and then 20 per day, up to 24 weeks long, which was the length of the study. All patients were at least 50 years old and had some signs of dementia. Here are the assessment tools that were used to assess the Alzheimer's patients in the trials. We have the SIB, the Severe Impairment Battery. We have the ADCS-ADL, which is the Alzheimer's Disease Cooperative Study Activities of Daily Living Inventory, and the CIBIC Plus rating, which is a little bit more complicated. We have clinicians interview the same patients, 2 clinicians will interview the same patients, and then we compare the scores. The first assessment tool, the Severe Impairment Battery, We have a scorecard here on the left, which shows all the different categories that are looked at and the scores. Specifically, this is for severe impairment, and it can distinguish levels of severe impairment well, making it best for that application. There are many items. Technically, there are 51, even though it doesn't count one for one. It has a few things marked with letters as well. It is quite time-consuming, and the score goes from 0, which is the worst score, to 100, which is the best score. The second tool is the ADCS-ADL, or the Alzheimer's Disease Cooperative Study Activities of Daily Living Inventory. So a quick note about the items shown below. These are paraphrased. They're not the original name for all of the items because they're too long and it's too much information to put on one slide. However, this is a general gist here. So our score range goes from 0 to 53. 0 is the worst score, while 53 is the best. The patient does not have to take this test directly. You can actually ask a caregiver about how the patient is doing in all these categories, making it a little bit easier to administer the test and faster to give in comparison to the severe impairment battery. However, this means that the results may be comparatively subjective. This is the CIBIC plus rating, so clinician's interview-based impression of change plus rating. It is an assessment method for dementia patients that looks at global function, and it includes information from patients and or caregivers. So as we see here, we're going to have at least 2 caregivers that assess how well a patient is doing and if they're getting worse, getting better, how exactly they're doing, and we compare those scores. This test does take 10 to 40 minutes with a trained clinician, making it more complex and time-consuming, and the fact that you have to have clinicians trained in the test does make it a little bit more complicated. Let's move on to the results from the MEM-MD2 study. So the last observation carried forward, or the LOCF that I have listed here, this is a method of inputting missing data in longitudinal studies. So if a person drops out of a study before it ends, then his or her last observed score on the dependent variable is used for all the subsequent observation points. The OC, or observed cases, these only include readings at week 28, meaning only patients who completed the study. All results were statistically significant and in favor of the memantine donepezil group in this study. Here's an excerpt from the study. You can read this if you'd like to read about the secondary endpoints. All results were statistically significant and in favor of the memantine donepezil group, as we stated before. However, it was pointed out in a peer review that the difference in percent not worse may show that the effect of the Namenda was actually not clinically relevant for the reasons listed above. Here's the second study that led to the approval of memantine. Study 9605, a prospective randomized placebo-controlled double-blind multicenter trial in patients with moderately severe to severe Alzheimer's disease. The dates are listed here. The treatment duration was 28 weeks, and the regimen was placebo versus memantine, 5 milligrams PO QD for 1 week, then 10 milligrams for 1 week, 15 milligrams for 1 week, and then 20 milligrams PO QD. The same concept from the first study carries over here. We have the LOCF here, we have the OC, and all results were statistically significant and in favor of the memantine donepezil group, except for this one. And that's only because it was not significant, because the p-value is above 0.05. 5 of 6 results were shown before to be statistically significant and in favor of memantine over placebo. However, peer review noted that there seems to be some attrition bias in the results. There were patients on memantine that dropped out doing much worse than the patients on memantine that finished. Comparatively, the patients that were on placebo who dropped out were not doing as badly as the ones that were on memantine and dropped out. Therefore, the results could show attrition bias in favor of memantine. Memantine study number 3 was study 9403. It was a randomized placebo-controlled double-blind multi-center trial. The N was 158 and it started as 166. Treatment time was 12 weeks, and we had placebo versus memantine, 5 milligrams PO QD in the morning for 1 week, then we move up to 10. Here are the results of the trial. All patients had dementia of some kind and were care dependent. Dementia of the Alzheimer's type is DAT. So we're comparing DAT versus all types of dementia. All 4 groups showed a statistically significant favor for memantine. In addition, there does not seem to be a dropout bias in the study, and both groups tended to improve over time, although the memantine group did do much better than the placebo group. Let's take a quick look at a special section I included here. This section will focus on 3 closely related monoclonal antibodies, or MABs, for Alzheimer's dementia that have been making big news in the pharmaceutical industry lately. The first medication I'd like to look at in this section is aducanumab, or ADUHELM. It was shown to reduce amyloid beta and slow cognitive decline in patients in Phase 2 trials. Phase 3 trials emerge and engage halted with divergent data. And this was also approved anyway on June 7, 2021. This approval in particular has sparked debate in the scientific community and was a large controversy. I will shy away from discussing the debate or any strong opinions on the morality of its approval and simply look at what we have here. It was approved, it seems to be, because it had the ability to remove amyloid beta plaques. However, there is still no evidence that the amyloid beta clearance is correlated with less cognitive or functional decline, even if we saw that in the trials. A similar medication that's still in the research pipeline in Phase 3 trials is donanemab. It has not yet received FDA approval. The Phase 2 trial found that donanemab was successful in slowing the development of Alzheimer's dementia, but its side effects were still problematic. We do see that in the study of LY3002813 in participants with early symptomatic Alzheimer's disease, or the Trailblazer ALZ study. Cerebral edema is the side effect of concern. It was seen in high doses, but it is mostly asymptomatic. Some Phase 3 trial results are expected to be released in 2023, this year. Third medication in this section is lecanemab, or Leqembi. I will also take a close look at the dementia rating tool that was used in the trials for lecanemab in the following slides. Van Dyke et al. In January 5, 2023. There was a Phase 3 trial, lecanemab in early Alzheimer's disease. The N was 1,795 adults, all with confirmed amyloids in the brain. Patients on lecanemab had a least squares mean change of 18 months at 1.21, while the placebo had 1.66. This means that the placebo arm got worse faster in compared to the patients on lecanemab, meaning that it can preserve some brain function. The clinical dementia rating, or CDR, was used to measure the effect. It contains things like assessing memory, orientation, judgment, and problem solving, community affairs, home hobbies, and personal care. On January 6, 2023, the FDA gave an accelerated approval for lecanemab for the treatment of Alzheimer's disease. This is the Clinical Dementia Rating Tool, or CDR. It is scored from 0 to 3 in 6 categories, with a global score derived from the scores of the 6 categories listed. So we have memory, orientation, judgment and problem solving, community affairs, home and hobbies, and personal care. These 6 determine the score of the global score. We do have an option of giving each domain a score of 0, 0.5, 1, 2, or 3. This tool has complex scoring rules. We will look at some of the basic rules here, but there are many more available from the source for those curious about the intricacies of this scoring tool, especially the rules used in determining the global score. There is also a program available from the Washington University School of Medicine in St. Louis Knight Alzheimer's Disease Research Center website, which is cited here. This program can determine or calculate a global score for clinicians when it is provided the first 6 scores. Some of the simple rules here: when at least 3 secondary scores are given the same score as M, or memory, then the CDR global score is equal to M. If 3 secondary categories are higher or lower than M, and 2 other secondary categories are on the opposite side of M, then memory is equal to CDR. As we can see, this scoring system is somewhat complex and has many rules in determining the global score. Here's where the scoring for the global score can become a little complicated. I will skip my notes here for now, but you are free to pause and read these for more information from the citation provided. Specifically, this goes over some additional rules if the score is very complex, meaning that the patient is getting very different scores in different domains. Here is a slightly complicated yet succinct example scoring from the CDR tool that's cited. We can see that 3 domains have a score of 3, 2 domains have a score of 1, the memory domain, or M, is the only domain with a score of 2. If we recall from the scoring rules that we discussed, if 3 secondary categories are higher or lower than M, and the 2 other secondary categories are on the opposite side of M, then M is equal to the CDR score, or the global score. Now let's move on and take a look at more modern research into dementia, including a large review from Tanaka et al. In November 2022, and then a quick look at a figure from Cummings et al. In May 2022. Let's begin this look at Tanaka et al. With the targets for dementia treatments outside of acetylcholine and NMDA receptors. So amyloid beta peptides, we've discussed, they're strongly associated with and appear to play a central role in the pathology of Alzheimer's disease. Targeting these has been shown to reduce synaptotoxicity and improve cognitive functions in animal models of Alzheimer's dementia. We have beta site amyloid precursor protein cleaving enzyme, beta secretase, or BASE. This produces amyloid beta peptides. BASE inhibitors may be able to block the rate-limiting step in the amyloid beta peptide formation, leading to them not even being made. The sigma-1 receptor, or S1R, is a chaperone protein of the endoplasmic reticulum membrane, which mediates calcium signaling to trigger neuroprotective and anti-apoptotic events. Now let's move on to some of the medications that target amyloid beta. One of these we've talked about before, aducanumab or ADUHELM, we've already discussed here. The proposed mechanism of the amyloid beta target is the decline in cognition in dementia is associated with the deposition of amyloid beta in misfolded oligomers. So if we can prevent this, we can potentially help to prevent the decline in cognition seen in dementia. Solanezumab is an amyloid beta targeting medication that failed to reduce cognitive decline in phase 3 clinical trials. Aducanumab, as we know, targets aggregated amyloid beta. It was shown to reduce amyloid beta and slow cognitive decline in phase 2 trials. The phase 3 trials were halted because of divergent data. However, it was approved in June 7, 2021. Bapineuzumab failed to reduce cognitive decline in phase 3 clinical trials as well. Sorenzumab, it binds to amyloid beta monomers and oligomers, and however, it did not meet the specified endpoints in the phase 2 trial and was given up on as well. Gantenerumab failed to reduce cognitive decline in phase 3 clinical trials. Pozelimab was abandoned after phase 2. GV971, or sodium oligomanate, was a carbohydrate drug that was abandoned by Green Valley after phase 2 due to the economic situation of the company. In phase 2, the drug was able to meet benchmarks on the ADAS COG, however it failed on the CIVIC Plus and the ADCS ADL and the NPI. AN1792 was a vaccine for amyloid beta. It was discontinued due to 6% of patients in trials developing meningoencephalitis. However, a follow-up study showed that antibody responders experienced significantly less cognitive decline. In general, amyloid beta targeted therapies have been largely unsuccessful. Now let's take a closer look at BASE inhibitors. These BASE functions by cleaving the extracellular portion of the membrane-bound amyloid precursor proteins, resulting in production of soluble extracellular amyloid beta. The function of amyloid beta is not well understood, as we said earlier, but studies have found that animal models still function with no noticeable loss of function without amyloid beta. So BASE inhibitors block the rate-limiting step in amyloid beta production, meaning that it's not going to be produced. Some examples here: verbucistat, abatistat, and lanabistat showed no efficacy in worsened cognition for prodromal early or mild Alzheimer's disease in phase 3 clinical trials. Atabesistat showed toxicity in the ALZHEIMER'S 2009 CDG trial. And E2609, elambesistat, is still under phase 3 clinical trials. Interim data has shown no negative effect on cognition. However, it reported no significant improvement in cognitive scores and adverse effects. Next is a look at the sigma-1 receptor, or S1R. This is a chaperone protein of the endoplasmic reticulum membrane, which mediates calcium signaling to trigger neuroprotective and anti-apoptotic effects. The medication we have here is Anavex 273, or a blarcamesine. It is a S1R activator that reduces mitochondrial dysfunction, oxidative stress, protein misfolding, inflammation, and blocks tau hyperphosphorylation. All of these things are associated with Alzheimer's disease. The Altiform 2020I is a phase 3 trial testing Anavex 273 in early Alzheimer's dementia. No data is out yet. We also have GV971 in this class, which is sodium oleomannate, which was abandoned by Green Valley as discussed earlier. Tanaka et al. Discusses a list of novel approaches or mechanisms for use in dementia. They are organized here in a chart, and we will review each target in the following slides. The first target in this section is the long interspersed nuclear element 1, or line 1. The proposed mechanism here is that line 1 is an autonomous retrotransposon that creates genomic insertions via an RNA intermediate. Evidence has shown that an increased level of line 1 is associated with an increased risk of cancer, neurologic diseases, and psychiatric conditions. L1 transposons comprise approximately 17% of the entire human genome. Currently, there are no medications with line 1 as a target. The next target is microRNAs. The proposed mechanism here is that disorders of microRNAs interactions have been observed in mild cognitive impairment in Alzheimer's dementia. The genes associated with these microRNAs are related to the regulation of mitochondria and aging, according to Brito et al. 2020. Taguchi and Wang in 2018 found that microRNAs have been linked to cancer, autoimmune diseases, and neurodegenerative diseases. Tanaka and Visay 2020, the disturbance of microRNA interactions have been found in AD-PD, Huntington's disease, and ALS, or amyotrophic lateral sclerosis. Catanesi et al. In 2020 found that microRNAs may be a diagnostic biomarker and a possible treatment target in neurodegenerative diseases. No medications targeting microRNAs have been developed yet. However, this is a potential target for use in the future. Now let's look at ApoE4, the gene that transcribes apolipoprotein E4. So this contributes to amyloid beta accumulation and tau hyperphosphorylation, according to Lanfranco et al. In 2020. Another gene here, TDP43, is a protein involved in many kinds of transcriptional repression, notably HIV-1, pre-mRNA splicing, and translational regulation. TDP43 has been found to be present in the brains of 65 to 80% of Alzheimer's disease patients and has been shown to be associated with a progressive hippocampal atrophy. ApoE4 has been linked to an increase in TDP43 deposition as opposed to the other alleles, which may be a potential mechanism for how ApoE4 contributes to Alzheimer's disease if it does. No drugs targeting ApoE4 have been developed yet, however. This next session involves a look at calmodulin binding proteins, or more specifically the stabilization of the calmodulin interaction. The proposed mechanism for calmodulin binding proteins as a target is that it plays a central role in calcium homeostasis. Calcium homeostasis can become dysregulated by oxidative stress, formulation of amyloid beta aggregates, inflammation, and exotoneurotoxicity, and tau hyperphosphorylation. All of these lead to neural loss and may contribute to dementia, according to Karoba et al. In 2021 and Tanaka et al. 2020b. However, disturbance of the calmodulin interaction leads to cognitive dysfunction and thus dementia. Many other things are regulated by calmodulin and calmodulin binding proteins, including neuronal electrophysiology, glutamate receptors, including metatropic glutamate receptors and NMDA receptors, interactions with the amyloid beta and the regulation of the calcium ATPase receptors and ryanodine receptors in the plasma membrane. So far, no medications have been designed to target calmodulin. Finally, let's take a look at the kynurenine analogs as targets. They are involved in the tryptophan metabolism pathway, and the KYN, or kynurenine pathway, produces reactive oxidative species, antioxidants, anti-inflammatory agents, NMDA receptor agonists and antagonists, and immunological ligands, among other several bioactive compounds, according to Tanaka et al. In 2020b. Turek et al. In 2020a found that the alteration of the kynurenine pathway enzymes and metabolite levels can contribute to the development and progression of neurodegenerative disorders. Therefore, kynureninic acid has become an interest of researchers due to its antioxidant, NMDA antagonist, and aryl hydrocarbon ligand activities. Tanaka et al. In 2020c found that kynureninic acid has been shown to have antidepressant effects in animal models. KYNA does not penetrate the blood-brain barrier well, and there is currently extensive research underway to make an analog that will freely cross the blood-brain barrier. AV101 is a medication that was developed for the treatment of Alzheimer's, dementia, and anxiety disorders. It did fail in phase 2 trials because it had negative effects in MDD, or major depressive disorder. Here are some other proposed targets discussed in the literature. Some of these may be addressed in dementia care to take a more holistic or comprehensive approach to caring for dementia patients. However, these are not chemical products that involve the underlying mechanisms in dementia that we could create a drug for. Some notes about an agent named magnesium L3NA are shown here. This was not included in Tanaka et al.'s review, but I did find it relevant to supplement the review given the discussion about this compound here. So we have in Stutzky et al., January 28, 2010, magnesium L3NA can efficiently elevate brain magnesium. So brain magnesium is associated with neuroprotection. The study found that both magnesium L3NA and magnesium gluconate in milk have higher bioavailability. We also see that elevation of brain magnesium enhanced learning and memory in young and aged rats. The elevation of brain magnesium increased NR2B, which is associated with better results on learning tests, and in MDAR, the process of learning, memory, and neuroplasticity relies on this compound, signaling and syntactic plasticity. The elevation of brain magnesium increased the number of presynaptic boutons in the hippocampus. A bouton is an enlarged part of a nerve fiber or cell, especially an axon, where it forms a synapse with another nerve. These findings suggest that an increase in brain magnesium enhances both short-term synaptic facilitation and long-term potentiation and improves learning and memory functions. Now let's move on to a section of the review that discussed repurposing existing medications for use in dementia patients. So we have examples here. Masitinib, a tyrosine kinase inhibitor for the treatment of mast cell tumors in non-human animals. It is currently in phase 3 trials for ALS, or amyotrophic lateral sclerosis, also called Lou Gehrig's disease, a disease where nerve cells degenerate, which reduces muscle function. Atorvastatin is also being studied. Feldman et al. Noted that there was a hypothesis that statin use could slow the progression of Alzheimer's dementia. They studied atorvastatin use in a clinical trial with 640 patients with mild to moderate Alzheimer's disease. However, they found that atorvastatin was not associated with a significant clinical benefit over 72 weeks. Guanfacine is also being studied. Evidence exists that guanfacine may have neuroprotective effects. Currently, it is being tested in a phase 3 trial for Alzheimer's disease. Guanfacine is a noradrenergic, and noradrenaline levels are lower in Alzheimer's disease and ADHD. Icosapent ethyl esters, or EEPA, is currently being studied to target oxidative stress, which may contribute to Alzheimer's dementia. It is currently in phase 2 and phase 3 trials. There is also a trial of losartan, amlodipine, and atorvastatin plus exercise studied for the effects in cognitively normal older adults, patients with hypertension, patients with subjective cognitive decline, and patients with a family history of Alzheimer's disease. This was completed in January 31st, 2022, but no results have been posted as of April 21st, 2023. Z-drugs, including zopiclone, azopiclone, zalopon, and zolpidem, studies have shown that the possibility of using Z-drugs for insomnia and dementia may be helpful. However, Z-drugs and benzodiazepines have now been linked to dementia, according to Torres Bandia et al. 2020. The conclusion listed here says that they found the incidence of dementia was not higher among all benzodiazepine users. Short-term half-life benzodiazepines and Z-drugs increase the risk of dementia with the highest doses, especially in female patients, showing a dose-response relationship. Auvelity, or dextromethorphan bupropion, is a new NMDA receptor modulator. Dextromethorphan acts as an antagonist to the NMDA receptor, and bupropion acts as a CYP2D6 inhibitor by taking up the available enzyme, therefore allowing dextromethorphan to not be metabolized. The FDA approved this medication for the treatment of depression in 2022, and it's currently available now. It is now in Phase 2 and Phase 3 trials for agitation in Alzheimer's dementia. Citalopram is also being studied for dementia. It's been previously found to be effective in reducing agitation in Alzheimer's dementia. Methylphenidate has also previously been found to be effective in reducing apathy in patients with Alzheimer's dementia. Mirtazapine is currently being studied for agitation in dementia. No results as of April 21, 2023 have been posted. Metformin is being studied because it has been found that diabetic patients on metformin had a lower risk of dementia compared to patients on sulfonylureas. Finally, ALZHEIME'S is a combination therapy using a cromolyn inhaler and ibuprofen tablets. It has been shown to reduce amyloid production and inflammation in the CSF. Cromolyn stabilizes mast cells and therefore reduces cytokines and inflammation. It is currently being studied in Phase 3 trials. Finally, here is a quick look from a figure included in Cummings et al. In May 2022. This approximates the complexity of the research surrounding agents intended for use in Alzheimer's dementia, the progress each one has made, and the different mechanisms that are being researched in Alzheimer's dementia therapy. Thank you for watching.